So I think this will be a shift. We're going back up to the very high level of what's our healthcare system and how are we doing. And well, fortunately or unfortunately, this title of Confronting the Gaps in Healthcare Performances, there still are gaps. So we haven't closed the range of performance that you can see across the country. I worked for years, more than 20 years at a foundation in New York known as the Commonwealth Fund, and we had the good fortune of having a very wealthy family who had no children, and as of 1918, they just gave all their money to the foundation, and they had more money than Carnegie at that time, so we've been able to live, the Commonwealth Fund lived off it. But it was able to fund studies and do work, and early on, about 10, 15 years ago, we thought, how does the U.S. compare if we look across the country, how we look at states, at local areas, and if we can find examples of high performance or low performance that we can have aspirations. So these can be benchmarks, like at least go to the average or go to the top, and try to understand if one area is doing better than another area, what lies beneath those performances. I'm not going to be able to give you much today because we've only got a short amount of time, but I'm just going to give you a bird's eye view of some of what we found on the variations. And as this slide says, there's huge variations across the country, sometimes 2- and 3-fold differences between the leading 4 or 5 states and the lagging 4 or 5 states, or the leading areas of the country that are clustered around urban or rural areas. And even if we got up to average as a country, we'd be doing a lot better. And if we could move everyone to the above average and be moving up, we'd do even better. The one clear shared concern is costs, and I'll show you a few slides across that. That varies less than you would think than do healthcare outcomes. But there's a real potential. We're living in this century with a capacity because of IT and different tools that we can bring to teams and virtual teams where they can communicate visually with each other without being in the same room. We should be able to innovate in our delivery systems in a way that we get better results for less cost with better access. So that's part of the theme here, that the capacity to do better. But it needs people like you. We really need leaders who step outside their daily occupations to say what's going well, not what's not going well, having a vision of what can happen. Because without leadership, we won't change systems. I'm going to be using data that comes from a series of scorecards, and you all have the charts in your pack. There's a resource list at the back. All of the data I'm showing you is available in a data website. So if you want to drill down to Alabama or Florida and compare it to other states, you can pick your state and say, I want to see how it's doing on this or that, a metric. So I'm just showing a few. And this is updated every year. So I'm trying to give you the most recent updates on it. We went below the state level a few years ago, and I'm still using the we, even though I retired from this, but we went to a more local Montgomery, Alabama, or Louisville, or different urban areas to say within a state do we see variations, and I'll show you 1 or 2 slides related to that. So to start out with, we have a color scheme to make it kind of easy if you can't read the print. The darkest blue in the state map means the bottom quartile of states. The next darkest is the next quartile up. The lightest color is the top quartile, just dividing into those groups of states. And this picture has not changed very much in terms of which states are in the bottom quartile and which are in the top. But within each of those states, there's some metrics that states are doing relatively well or relatively worse. And in some cases, the gaps are starting to close a little bit, which is good. The good news. The spread isn't quite as big. Unfortunately, on some, and the ones that we've been closely watching in the last couple of years, such as death rates and outcomes such as dying early, have been getting worse rather than better. For a while, they were improving. The big positive light is access. Insurance expansions have made a real difference. And to just show you that, there are a couple maps in the very back, but I think I'll just stay with this one. All states, meaning every single state, has seen a decrease in the number of people who are uninsured, their uninsured rates. It's been quite dramatic in the states that also expanded their Medicaid programs, but even in states that didn't, the rates have come down, so that we see the worst state now not being as high a rate as it was a while ago, and the highest rates uninsured are still in Texas. The best states, some of the leading states, have gotten better, so pushing their rates nearer and nearer to 3%, 2% of the population uninsured. And this makes a real difference for practices. It means that people who are walking in the door have some ability to pay their bill. For patients, it means that they're more willing to seek out care early, with a few exceptions that I'll talk about on what kind of insurance people have. So that's one of the good news stories. Early on, we ran this graph, and we found that areas that tended to have better access, meaning people had a regular doctor, they were going in for care, they weren't going without care because of costs, there tended to be a theme that quality was better also. And it wasn't so much that access produced higher quality, but areas that had focused on access had also focused on quality. You know, that there was a systems approach to the way they thought about their systems. These dots are states. There were some states that did very well in access and also well in quality. And if you look at it later, you'll be able to pick where the state dots are. When I talk about access, aside from getting in for care, we've put metrics in that are preventive care, so recommended regular screenings. In this case, it's cancer screening. These rates have grown closer together over time, but there's still a big spread between the bottom performing states, where only 60 or 65% of people get recommended care, and top, where 76%. No state is at 100%, so that it's not that everyone comes in on a regular basis to get cancer screening. Cancer, as many of you know, if you've looked at clinical care, the U.S. in general has been doing better on cancer over time. It's been doing better with strokes, not resulting in death. Different cancers have different rates, but this early preventive, particularly for things like colon cancer, really makes a difference in terms of outcomes. This is a data point that we were able to put together a few years ago because the Medicare program has a drug database that lists what people are getting as a medication, not just whether they're getting a data. And one of the issues in the United States compared to some other countries is in some cases Medicare is the only data system we've got where we can look at all 50 states. This is all of it. These are drugs that the elderly are generally supposed to not get. It's like pediatrics was not supposed to get certain kinds of care. This rate has improved over time. These are drugs that you worry about in older people. They don't metabolize them the same way. They're more at risk for falls or delirium with certain medications. And it's been a list that's been around for a while. It's called the Beers list, but it was endorsed by physicians. And this was just run through the database. And if you can see the range here, some states there are at 4% or 6% or 7%, and some states are at 16% of their elderly population are getting these medicines. That's not good news. So it is a place to look. So aside from the opioid crisis, we also have some prescribing issues on prescribing patterns. One of the things we found when we could break it apart by income, and this has been a constant theme in these scorecards, is that the more vulnerable populations, and here it's people who are on the Medicare Part D part where they only qualify for help because they're low income. So we compared low income to people who didn't qualify. We find these big gaps within states between what low-income people receive and what higher income, meaning they're not low-income, receive. Again, variations across the states, and in this case, when we first showed this, some people in the audience observed that the higher-income people in the states that were doing less well had higher rates than the low-income people in the states that were doing well, so the yellow dots versus the blue. These rates have gotten better, but there's still a much bigger spread given that the protocols say this should be avoided. This is a metric that was developed. It was originally developed in the United States for some tracer conditions, and then it was expanded in Europe, and we're using here in the States. These are conditions that early death rates at an early age, asthma of kids resulting in death, diabetes before age 50 resulting in death, that should, with early preventive care and appropriate care, should be avoidable, or at least they're treatable conditions, as opposed to car crashes where the medical care system doesn't have very much to do with it. These rates, again, the theme is very wide variation across the country. And when we first showed this chart, people who knew the South said, well, what you're picking up is the minority rates are much higher than the white rates. So we said, well, we'll do one map that just pulls the African Americans out and just looks at the white early preventable death rates. And as you can see, if you can see the numbers down in the chart, there's a twofold variation here between the lowest rate state and the highest rate state. Unfortunately, these have started to creep up. For a while, they were coming back down. And the things that are going up are things like deaths from overdoses, deaths from suicide, some drug-drug combinations. So you see the opioid crisis start to come into some of this. The first set of charts, by the way, are just to show you some data, and then I am going to we can do something about this news. The premature death rates, that same statistic, these little dots are within a state how much variation there are. So it's not easy to see how much variation are in some of the smaller population states, but big states where you live really makes a difference in terms of what these premature death rates look like. So some areas have started saying, if I'm high relative to places that look like me, why? Let me look underneath. Where is my problem? We've also, when we've looked at death rates by education, which is another metric of way of talking about disadvantage, and here it's people who never went beyond high school before they were 25 or 30, so they only have a high school education versus college degree. There's less variation across the states in death rates among college education than there is among people with less education. One person, when we first did this chart, said, well, how many people have only a high school degree by the time they're 25 or 30? And the answer in some of these states is 40% of the state. So this is not a small percentage of the state with these high death rates. And when we stepped back and looked at these, and I'll show you a few other indicators later, people said, what's going on here? What's underneath poor outcomes? And some of these comparisons were done internationally as well. So we did a U.S. to other countries and then started looking in the United States. And we looked better than other countries on a few, but a lot worse on some others. So underneath, a series of physicians and healthcare leaders said, we can see a lot of evidence of weak primary care, fragmented care with people moving from one place to another without information flowing with them. Evidence where two places are not performing at the same level, even though the market doesn't seem to be working, that people don't gravitate to the better performing one versus the worse, often because they don't know that the performance is different. And there aren't many market signals that you want to go here and avoid there. And then what do we do about it if we can start to look underneath? And this is where care systems are analyzing their own information in local. For starters, if you can't get into the healthcare system, your healthcare outcomes are less likely to be good. So getting people in is important. Building up our primary care foundation, and I'm going to talk a little bit about medical homes, with something where the home is embedded in a larger care system, innovating in our care systems, thinking about teams, not just silos of care, but people working together, paying in a way that rewards people for doing well and allows them to keep some of the savings, provides positive incentives, removes barriers, and then starting to look at the social factors. And I'm going to say a little less about that today because I don't have time, but there's more and more interest in saying what's happening at home, what's happening in the community, what are people's jobs, and what extent the medical care system can link with social systems to say we can do something about this if we know what the problem is in these patients. So this is just a real simple diagram that the payment reform either enables or puts up barriers to a care system figuring out what else it can do. Information systems are becoming more and more critical, knowing how you're doing, but knowing how to communicate with each other and building a foundation where access is guaranteed. We have a lot of examples, and I'm only going to give you a few today, but at the national, state, and local level, this is an era, and this has been going on for a decade, and it will continue to be, of people trying new things, of learning from others, going and visiting a place where they hear about something going on and saying, let me see what would work in my area. I won't do it exactly that way. I'm going to adapt it to my conditions, and thinking about doing it differently in my area of the country. One of our issues has been if we could get the Medicare program or the Medicaid program to go along with paying differently, can we also get Blue Cross Blue Shield, Aetna, United to go along? Because if one system pays this way and another pays that way, and we're keeping different information systems for them, it's hard to make it all work together. So there's increasing focus, but not very successful for a while, of multi-payer. Can we get the payers on the same page, at least incentives on the same page? So I think you probably have seen this, if not in the last couple days, but on other times when if anyone has been talking about care systems. This is Ed Wagner's. It was originally a chronic care model, and saying what do we mean when we say patient-centered primary care? And it's a primary care system that's in the middle of a larger system that's linked to patients. It's around patients, but it's linked to the community. It's linked to hospitals and specialists, not in isolation. And all of these are working in a care system way. And when you see one that's working well, you know it. You know the functionality that this can bring with it. And these pictures, it's getting more crowded each year as I try to put some examples up. So the new one this year is the Rio Grande Valley Health Alliance, which is out in McAllen, Texas, which was rated one of the most expensive Medicare areas in the country a few years ago. And I'll talk about what they've done, but it also had very bad outcomes, healthcare outcomes, for both under 65 and over 65. So that's a new one. North Carolina has been doing rural health clinics and an expanded program for years. Denver Health is a public health system, but it's put clinics in the schools. So part of its way they think of primary care is going to where young adolescents are to make it easier to see them. The guided care system is with mentally ill, severely disabled. Geisinger is a rural health system that has focused a lot on the elderly. People know what Alaska looks like. So they vary a lot, these care systems that have said, let's think of a different way of doing primary care. But the constant theme is they're looking at teams and different ways of linking people together and thinking of it as a home in the middle of a care system. Out in the out on the West Coast, Group Health, several years ago, when it converted to a different way of delivering primary care, one of the things they wanted to know was, what did it feel like for physicians? Did they like practicing this way? And they got a resounding yes, that the doctors much preferred practicing this way. This is true in Vermont, this is true in Geisinger, this is true in each of these places, because they were seeing patients in a different way. They were spending more time with the sickest patients. They were handling the worried people virtually. They were cutting down visits when people didn't need to come and see them. They were being paid in a way that paid them for their time. So this whole reorganization of care was satisfying for doctors and got rave reviews from patients. And I'm going to talk a little bit more about a couple places in a minute, but some of you may be part of these initiatives because the federal government tried to, since the Affordable Care Act, but also just more generally, said let's link physicians who are trying to practice in a different way so they can each learn from each other. So there are these primary care multi-payer initiatives trying to align all the payers. And I was at a conference where Aetna was talking about paying their doctors differently in their primary care networks. that they wanted to pay them partly just for the patients that were enrolled with them, so a per patient per month payment, and then a visit rate so that you got two flows of money. And the patients started complaining because they were getting bills where they didn't owe anything when they hadn't made a visit. And Aetna said they were unable to change their claim system to handle a per patient per month, that they only knew how to do visits. You know, I think they've since fixed this, but insurance companies trying to figure out different ways of paying and getting on the same page. So there are a lot of practices who have joined these. This has been authorized as an option for health homes within the Medicaid program, where the focus is on physical health as well as mental health, with a complex need, core services, where they bring in social services, PT services, transition and follow-up care services, referral to social services, saying, you know, we've got our sickest patients, and we need to do differently for them than we would do for a normal, healthy adult or a child. So this is both children and adults. Health homes, these are states that have initiatives to pay differently. Again, this is within the Medicaid program. And they're licensed to pay differently and pay more. So the practices that enter these get paid more. Accountable care organizations, or ACOs. The last few years when I've been here, someone has given a lecture on these. What I find interesting about this map, the dark blue is areas that have 20% or more of all the people in that area covered by an affordable an ACO arrangement, and this is private and Medicare. This didn't exist 9 years ago. The term didn't exist. And the arrangements in terms of payment have been paying care systems differently with if you're on a risk arrangement with them, a share of the savings. So if you can reorganize your care and deliver care for less or less than the expected rate of increase, you get to keep a piece of it. And this, in some care systems, have meant the money gets plowed right back into a doctor's pocket or back into the tools that practice needs to reinvest. And I will give you 3 examples of that just in a second. But I want to talk about what all of this movement of care systems has looked like when people really focus on it. And it's a focus on the highest cost patients. This graphic, when I first encountered it about 30 years ago, hasn't changed very much. And what's amazing, if you look in the Medicare population, that's what this looks like. If you look at an employed group, that's what it looks like. That the sickest 10% of people account for 60 to 65% of all the dollars. The 50% healthiest are about 3% of all the dollars we spend each year. Now, you don't know which group you're going to be in advance. Some of us are fine this year, and then we have a heart attack next year, and then we're up in the other group. But the other way of thinking about it is 50% of the U.S. population could stop going to get health care altogether, and 3% of our dollars would disappear. It's all focused in that top group. So care systems are trying to figure out who are those people and how many people are in that group year after year after year, and what's happening to them. Where could we lower their costs by delivering more effective care, affording doing things twice, doing things we know we shouldn't be doing just because we didn't know they'd already been done, handoffs from one place to another and more continuous care. A lot of focus in that big group is on hospital readmissions and admissions in the first place. This is a group that's in and out of the hospital all the time, multiple times a year, or in and out of the emergency room, that top 10%. They're frequent flyers, is the way airlines would talk about them, but they're in and out. They're touching lots of them. So understanding where they are, if you can save one hospital admission, you save a lot of money that can be spent in a different place by preventing something that happened to it. One of the big incentives that was put on is hospitals face a penalty for high readmission rates. And people weren't sure whether a penalty would matter or not, so this is what has happened since the penalty went in. But what a lot of people think is no one ever knew what their readmission rates were. And when hospitals were told what their readmission rate, one hospital said, I don't think my patients have come back that often. They said, well, they don't always come back to you. 30 days after you discharge them, they came to another hospital, and we're just feeding you back your hospitals and what went on. And what Mass General found when they were looking at redesigning their whole systems is that part of the story was when they let a patient leave the hospital, they discharged the patient rather than figured out where they were going. And they did an experiment, with a demonstration program where their sickest 5,000, 6,000 Medicare patients, they handpicked the very sickest, and they started looking at what had happened when they'd been in the hospital and when they left. And the doctor who was describing this, they said one thing they found was these patients were on 13 to 15 medications, and 100% of them had the wrong list. You know, that something was on that list that shouldn't have been on, that was contraindicated, but no one had cross-checked what they were on before they went in, what they got during the hospital when they were leaving. And so they went through a care system change that said, we're not just going to discharge someone, we're going to have someone follow them back to the primary care practice. We're going to assign nurse practitioners who are specially trained for the elderly to work with this group of patients and the physicians. They lowered death rates. They decreased the use of the hospital by about 25%. They decreased the use of the ED. They decreased the use of nursing home care. And it was a care system innovation that they are now trying to spread with the sickest patients. And the Dr. Tim Ferriss, who was part of this, he said doctors started, this was a tailored demo that only some people got this extra person put in. Doctors started coming in and saying, I have some patients that I think should be in that group. And they said, well, they don't quite make our top 10%, but people liked this additional way that they were delivering care so much that they now wanted to opt into it. Cincinnati Children, going to the other end of the age spectrum, did a study, and this is a major teaching hospital in Cincinnati for kids, but it has a huge primary care population and clinic, half of whom are Medicaid, low income. They did a study of their asthmatic kids, so they knew the kid had asthma, and how often they were hospitalized. And they found this kind of pattern in the Cincinnati area. And they said, these kids aren't that different from each other. What's going on? That some of them are coming into our hospital a lot for admissions. We're the same primary care practice. You know, we're not delivering different care. They went out into the homes, and they did home visits for the first time, and they found dirty rugs, poor ventilation, smoking, some issues with the home, and then they started doing a more specialized treatment. And I'm just going to show you, wait a minute, I got to go back a second. They put into their medical records social and economic risk characteristics of the family out of this asthma study. So they found out, you know, single parents that were working all the time, broken homes, alcoholism or mental health problem, and when that child came in, a different team was seeing the family, and they started working with the family around children's care. And on the asthma story, so I don't know, they were going to work on infant mortality next. On the asthma story, they emptied their hospital beds of asthmatic kids. They cut the rates down so substantially, so they could reinvest some of those savings in an effort to really know their populations. This is the Rio Grande Valley Health Alliance that I mentioned out in McAllen, Texas. They were written up several years ago. You can find Atul Gawande wrote a story about McAllen about it was high on the end of everything. When Medicare ACO arrangements came in, a group of physicians in the area, primary care practices, says, let's join together, do an analysis of who our most at-risk patients are and what's happening to them. So they figured out who these patients were. They got information back on where they were going. They found a lot of use of skilled nursing homes, very high rates of diabetes that was out of control diabetes, so ending up being hospitalized for diabetes. And because of the changes they made, they saved enough money that all the physicians have gotten 10%, 50% increases in their incomes. They poured back in, year after year after year. And they were able to expand the nurse practitioners and care systems they put in. And I was just looking at recent data. This same area of Texas has had negative cost growth for the under 65, and it has negative cost growth for the over 65 over the last several years. We don't see negative rates of growth very often with better outcomes. So that's the kind of story we would really love to see more often. Bundled payment initiatives are out there, another kind of payment reform. And when these first came in, some of the hospitals that got interested in them, when surgeons discovered that they didn't know the price of the devices they were putting into people's bodies, hip and knee surgery, the actual device, and they discovered they could get a better rate if they would bid out the device price and get some competition going rather than taking 15 or 16, having special relationships with device manufacturers. They saved enough initially in some of these bundled payment that the physicians' incomes went up, and it caught people's attention and said maybe bundles make sense because we can find out more. But this has been spread, and I don't know how many of you are in these arrangements, but again, it takes a total cost of care and says the patient before they get into the hospital, during the hospital, and after. So it takes into account, are they coming back again, or did you do it right the first time? Telehealth, that was mentioned earlier today, but telehealth and electronic communication more generally is the new innovation out there that's been around for a while, and we're just beginning to learn how to use it. We do have the state barriers where you can't cross state lines very easily unless the state allows you to have a license in 2 states. But we found people overcoming those barriers. This is being used a lot in other countries like India, low-income countries that say, forget barriers, we want to use this new technology. The VA has been using telehealth for a while, but we've seen a lot of examples, very creative examples of where you've got super specialized people located in one area and internal medicine or less specialized specialists out in a more remote area. And you can do virtual visits where you can have the patient and you can be sharing records. Mayo was doing this in North Dakota with difficult OB-GYN patients, working with doctors there. New Mexico has been doing it with rural clinics where they specially train nurses and they work with the consultants in Albuquerque and they have regular meetings with them on what's your most difficult patients. And there they're doing it with mental health, alcohol, and different kinds of abuse. And the insurance systems are referring patients to these teams. These are the tough patients. Some of them are homeless and they're working a lot on them and have proven they've saved enough money to make it worth the insurance company paying for the care systems. Care South in South Carolina is expanding it to 13 clinics. Emory is doing tele-ICU. So I can't get enough of these examples on the screen because this is starting to happen a lot. And one of the things, a care system out on the West Coast called Kaiser that you probably have heard of, it's a really big integrated care system. They told me because these phones, these iPhones that have come out, have such good imagery on them, they can send people out to their homes, do home visits. You can take a picture of skin. The dermatology uses a picture of this, is this a rash? What is this? Before, and bring it up to the medical record. But they can send home visitors to take pictures, to do nurses out to see what's in the medical cabinets, but also use it as a diagnosis tool. So this is becoming a portable technology that allows the doctor and the nurse to communicate back and forth in a way of using extenders very differently. I get so excited when I hear different systems using this. So the first time I heard the VNA in New York doing it, I've kept this slide in because they said when they started doing home visits, they were regularly calling up the doctor and sending a picture in and saying, this is what's in the medicine cabinet. Do you know what this patient is on? And can you help me go through these meds and decide something differently on it? And then they're telling them on what conditions, and these were elderly, disabled patients. And care systems started saying, we need those kinds of going out and seeing what's happening. And one of the reasons people become more interested in this is these rates vary enormously. So these are how often is a nursing home patient hospitalized or rehospitalized. So this back and forth to the post-acute care has started to be a focus. A lot of the ACOs have made money by reducing that use. They just focused on where people were going. One physician stood up at a meeting and said, you know, we noticed that when we sent people out to a nursing home or rehab, some of them sent people back more often with problems. And I decided I'd go visit them. No one had ever visited the places we were referring people to, and we decided to try to figure out which were the better places. So this notion of coordinating across site, and this just shows you some of these statistics. They're pretty startling to see 28% be readmitted within 30 days in some places and only 12 in another. When you see this variation, something is going on underneath it. Some people have focused directly on nursing homes within the nursing home. I don't know whether anybody is a nursing home administrator here, but saying, can't we train the frontline people in nursing homes to do better care management, avoid urinary tract infections, avoid bed sores, recognize when something is about to be pneumonia, to catch it instead of just sending them to the hospital. The other thing that some conversions have been doing within nursing homes is if a person is really starting to be end of life, turning the nursing home into hospice care, you know, training a change. So this is thinking about doing something within a nursing home. And one of the things that the homes that have done, this is just, you know, everyone gives themselves a name, so it was called Interact in this protocol they did, but it was trying to have those physicians that are going in also work with people to change the protocols and do some training, you know, do 2-week training, 4-week training, so they felt like their frontline staff had more knowledge than they had before, so they weren't, you know, dependent on the doctor coming in, but that communication is incredibly important. On trying to figure out what is going on. Geisinger, the one I mentioned that's up in rural Pennsylvania, actually decided they were going to have a nurse, one of their care team, regularly visit any patient that was in any of the nursing homes so they could do an independent assessment of what was going on, but trying to also make it continuous that you've been my patient. I'm hoping you're just here for a short amount of time. It's respite care. You're coming back, to not make it feel like I sent you there and there's no communication, but trying to cross these boundaries, even though they didn't own the nursing home, but trying to put a person in the home. So, you know, I just want to be conscious and do what was just done, just interrupt me as I go along. You know, I want to talk about, in closing, some of what I see opportunities and challenges as we look forward. I do think it's an era where we can learn from each other. There are incredibly exciting things going on if we can learn about them and go visit them. A group from Georgia said they'd gone up to visit Geisinger at one point, and they weren't going to do exactly what they did, but they got some good ideas. So finding out who's doing something interesting. There are all these tools that were in the Affordable Care Act, only some of which are being used well, and some may be bumping into each other. So I'm not going to talk very much about them because you've been hearing about them for the last couple days. But I do want to talk a little bit about costs. It came up earlier today, and it often comes up. This is the grid. Someone, I think it was over in the third row, said, you know, they've seen a U.S. compared to every other country. And this is one of the few metrics where we're always on top. You know, we're just not just a leader, but we are a leader by some. Whether you talk about the amount of money we spend per person or the share of our national economy we spend, the good news for the United States is that the percent of our GDP, that's the national economy, has leveled off of the last few years. That's really good news because it means we're growing, but we're growing about at the same rate as the economy. So we're not squeezing out. So people have been asking, what is underneath these numbers that is so high? When we've looked closely at it, or others have looked, we don't use more services. We go to physicians less often. We don't go in and out of the hospital more than other countries. Some countries are very frequent users of the hospital. We don't use more drugs per patient, you know, so the use statistics aren't higher, but every time we touch any part of the U.S. healthcare system, it's more expensive. So on the price side, it's quite a bit more expensive. And some of that, and I've got, when you leave here, you can look at my full chart set, I won't go into it, is the administrative costs that people have mentioned earlier. At every level of the U.S. healthcare system, in our insurance system, how much of the premium dollar is kept for administrative overhead. In our hospitals, the administrative cost of dealing with billing, forgetting everything else, is just much, billing and paperwork. So not just running the hospital, every hospital. In the physician's office, the studies of how much of a physician's time, nurse and other time, is built with third-party payers and with reporting. We just spend more on that layer. And that's a good 2% to 3% of that difference between us and the other countries. So it's a substantial amount of money if we could streamline our system to have people more on the same page. So it's not just the care system, but it's also all of those layers on top. This has been mentioned on drug prices. It's hard to talk about how much drug prices have been going up. I'm going to show you a graph in a minute of Medicare compared to private per person. But if it weren't for the spike in drug costs for the last several years, our Medicare per person costs would be almost flat. Where Medicare patients are going to the hospital less often, they're going in and out of nursing homes less often. But on drugs, the drugs they're using, and it's not more drugs, it's the price of the drugs they're buying, are way up. One of the things some other countries are doing, and it's not all countries, when a new drug comes on the market and you're not sure whether it's a lot better than the one you're already using, they put the drug company on a risk contract. And they say, well, we're going to peg the price somewhat higher than the one that's already on the market, and we'll study it for a couple years. If you don't get better results, we want our money back. We're going to put you back down to the price of the one that already existed. So not say that every new drug is necessarily better than the one we had before, but trying to do that comparison over time, really analyze it. We're not doing very much of that, so it's both a question of negotiating, and one of the troubling things more recently is not just the blockbuster brand new drugs that have come in, but some of the generics that have been around for years. Insulin. The producers of them have become monopolized. There are only a few sources of them, so that it's hard to resist the price increase. So we've got the two kinds of issues going on. It's not just the new ones. So I think it's something worth looking at. This is one of the statistics that doesn't vary much across the country. No matter where you live, health insurance is expensive. And I just want to show you the one other slide that I think it's important to remember. An earlier speaker was talking about if we only paid more upfront as patients, we would be more sensitive, we would be wiser purchasers. This is employer-based coverage, $1,000 deductibles. Nobody else in the world is doing this to their patients. We've only got one state left that's at $1,000 or less, the average. 5 years ago, employer packages didn't have $1,000 deductibles in them. I mean, we really have gone to let's have patients have more skin in the game. And the latest reports I've seen on doctor offices said doctors have had to work with collection agencies to recoup money from patients. 10 years ago, the average deductible in a single person plan was $100. Those are actual dollars. And so no, it's not. So this was 10 years ago would have been even lower, but this is from 2016 back to 2010. We were still at $100. So it's not, you're right. These aren't inflation adjusted, but $1,000. When I heard some farmers talking about their insurance, they called it property insurance, that they had $5,000 deductibles, and it was basically so they didn't lose their tractor. So this is the average. There are plans that have gone much higher. So I'm not saying there's probably not more room, but in other countries, one of the things they're worried about is people delaying care. Making a judgment, this isn't my necessary care, and the studies say people don't judge those very well. So in Germany, in a couple, they do it relative to income, so it shouldn't be more than 2% of your income or more than 5% of your income. If it starts to be 10% of your income is the deductible, it's a problem. So anyway, we've been moving in this direction to make people more market sensitive. Was there a question back there? Not. Yeah, so this is in the individual market, this market you've heard a lot about, these are $5,000 deductibles, not $1,000, for the silver plan. So we've really moved away from zero deductibles, a lot of cost sharing. So this is going on. So people are feeling that their premium dollars are buying them less coverage or less protection. If you compare Medicare to private over the last couple of years, several years, everyone has been really happy that there's been a slowdown, a big slowdown compared to leading up to the Affordable Care Act when we were seeing double-digit rates and 8%. If you go back into the early 2000s, it was at 10% a year, 15% a year. The biggest slowdown has been in the Medicare program. The reason private rates are up more rapidly, that people have been studying them, is because the prices they're paying have gone up more rapidly. In the private sector, in the insured population, use is down. So less use of a hospital, less use of this delivery system transformation has been going on. So there is some concern on, how much leverage do the big carriers have if you want to slow cost growth, but they're facing monopolies who are selling to them. So this is just, this is part of why there's an impetus around Medicare for all. Are you big enough to buy well? Other countries that have more than one payer bargain together as payers. So they don't necessarily go to a single payer, but they at least align cost increases. The ACA is out there. The other thing that no one talked about today that I just want to mention, the big news on insurance was the Medicaid expansion. Medicaid is now, in terms of number of people in it, bigger than Medicare. 66 million people are enrolled in Medicare. This is up by 16 million. Most of that is in states that expanded. The orange are the states that didn't expand to Medicare, the Medicaid program. They have also seen an increase in Medicaid. The thing the Medicaid expansion was designed to do for the states who took it up is to say, if you are working at minimum wage all year long, we want you to have health insurance and not be too rich to get an affordable care package. And so these states that have expanded that 138% of poverty, which is where Medicaid went up to, that'll get you to a minimum wage full-time job. It was designed to think about that you should, if you work for a living and your employer doesn't offer you coverage, we're still going to pay for your insurance. So the states that haven't expanded, I just want to give you a sense of how poor you have to be. And you've got some states in the room. If you, these are if you can get on. If you are a single adult without children and you're not disabled, you can't get on. It's not a category that Medicaid covered. So these are families of three. You would have to be a family of three earning $5,000 a year or less to get on in the state of Mississippi and have no assets. So the difference between what the Medicaid expansion did and existing rates is you have to be really, really low income in some states to get on if you're not a senior or you're disabled. So this is what the ACA was trying to do, is bring the floor up across the country for the lowest, the poorest citizens. So this is still on the table for states. Any state can still take this option to expand. And I'm going to close there. I'll take any questions on any piece, but my message on all of these and what we've seen with these scorecards is these statistics do move, and we've seen some states move from rock bottom to up to the average. The metrics are put out there saying, if you have a target, it's easier to see where you want to go. What are you aspiring to? The future is pretty uncertain because we don't know whether we're going to hold the insurance expansion, and it's been pretty important to a lot of providers that serve in areas where people are uninsured or temporarily uninsured. That Medicaid expansion, by the way, that 16 million more people on Medicare, that is more than the total individual market. We've never had many people in the individual market. So this is really a big news story. But we're going to have leadership. I mean, we're going to have to have people that say, let me look at my state, my county, my care system. Where can I go? What are we not doing well, and where can we go better? And I want to just end on that note with my little people slide of people not always pulling together. But unless somebody is pulling in a direction that we want to aim higher, the team doesn't do it either. And so it's not necessarily that I think people are going to agree we need to do it better, but where I've seen people come together and say we can tackle this as a group. Vermont is trying to tackle it as a state. There are whole counties. The answer is we can do better. Thank you.